Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the privilege of being your host today on this episode of GLI Live. This episode is really one that is too long in the making on such a crucial issue, the issue of the connections between liver health and kidney health. And so, hopefully no better time than March 2021, Kidney Health Month, and certainly no better guest, no better expert than Richard Knight, the president of the American Association of Kidney Patients, to kick off this series and to guide us through these really important and interrelated issues to tens of millions, hundreds of millions of patients when you think of it from a global perspective. So, Richard, hello and welcome.
Hello, Donna. How are you?
I'm doing very well today.
Excellent. First of all, I want to thank you for inviting me out. I'm a big fan. You've been doing tremendous work in the patient community, specifically in the liver community. So you should know that what you do is much appreciated by all of us out here. And that's, trust me, I know it's not easy. On top of that, we have to take care of our personal health.
Thank you so much. I really appreciate that because I have, had the privilege and pleasure of sitting beside you and, many boardroom and committee rooms here in Washington, D.C. for years. And we're pretty unassailable when we're together. That's one of the reasons I'm so excited about this issue. But I have learned so much from you over the years and, gained so much confidence from the courage of your advocacy and the persistence of it. And, not only the kidney community, but the patient community, the public health community, and whether they know it or not, policymakers and health systems have benefited from having heard your words and perspectives and insights. So thank you.
Yeah, well, perspective, that's what it's all about.
Yes. And so you have, like me, a lived experience
yes.
with these conditions. And so can you tell us a little bit about that and how
Certainly.
it informs your work?
Certainly. I spent a couple of years on dialysis, and like 32% of the patients who go on dialysis, I crashed into dialysis from the emergency room. At the time, I was under the care of a primary care physician. And that's one of the challenges with this disease and part of what motivated me to do what I'm doing. And that in many cases, it simply does not go diagnosed. And your kidneys will function until there's basically 15% functionality left. And then you're done. So I spent 2 years on dialysis, and I was very fortunate in that I was able to get a donor from a friend of mine who served on a board of directors at a local chamber. And she was kind enough to offer me a kidney, which I graciously accepted. But that it's a question of, is it a match? And as it turned out, it was pretty much a perfect match. So I'm 14 plus years out on my transplant. And what I've had to go through, first of all, let me say I live a great quality of life. Mm-hmm. But what I've had to go through informs me and basically motivates me. And that's what encouraged me to join the American Association of Kidney Patients, where there was a group of like-minded individuals who together we could really make some change and begin to look at things more from a patient perspective. Mm-hmm. And in our mind's eye, status quo is simply unacceptable. There's so much innovation that is available to us. We need to take advantage of it. And patients need to drive that change and innovation.
And I think that for me, my favorite definition of patient engagement, is that it's not actually patient engagement unless something changes. So while there's often a lot of emphasis on patient stories, if those stories don't change minds, change hearts, and ultimately change policies or compel some type of action, then it's ultimately disrespectful, and it's not honoring that experience.
And I find that we've had to redefine what patient engagement is. I had a doctor explain, no, that's not patient engagement. This is what patient engagement is. He says, why are you laughing? I said, well, why don't you sit here and let me tell you what doctor engagement is?
Exactly.
I said, with all due respect, you have no idea of what we, in the extent of what we do as patients. We're going to impact policy. We're going to impact innovation, whether it be, biologic, whether it be in medical devices. We have patients that are firmly involved in all of that, doing clinical trials. We work with a lot of firms to help them pull their clinical trials together so that they can be inclusive and have something that is appropriate for patients. So.
And we do as well, and I think that is some of the most gratifying work for me. One, because working at the very earliest stages to craft what becomes developed, what questions are being answered, ensures that ultimately they solve problems that matter to patients by the end of it. So it's no longer a question of just accepting what's handed to us or developed for us, and it's assumed that we're or trials that are assumed that we will enroll in that aren't really designed for us or by us. And so that work on redefining research, not just being a participant in it, is, I think, some of the most satisfying for me as a patient advocate, and what I enjoy training the patients in our Advanced Advocacy Academy to do. And I also want to pick up on the word innovation, because innovation is not just something that's new, but something that's new and makes a difference. And from the Kidney X project to countless other examples, you and your organization have been at the forefront of innovation. And so I'd love for you to talk about some of your work there.
I got to tell you, when you say me, it's not about me. My organization, the American Association of Kidney Patients, founded in 1969. The ultimate innovation was when one of our members dialyzed on the floor of the House Ways and Means Committee, and with some follow-up advocacy, chronic kidney disease, transplantation, and dialysis became covered by Medicare, which was revolutionary at the time. And it still continues to this day. A lot of the other things we've looked at is we look at them through the eyes of patients. Well, why is that? Why is this ugly bump on my arm called a fistula? Why is this so ugly, and why does it not work most of the time? And there are many new accesses that are becoming available. And I always tell patients, ask your doctor to consider it. Young ladies who like to wear short sleeves. I mean, if you don't have to have these marks on your arms, I mean, guys don't want them either, but I think ladies in particular, you don't want these star marks on your arm, particularly if there's an alternative. Right. There are alternatives now, which gets back to innovation. One of the greatest innovations we like to see implemented is early diagnosis.
Yes.
Like I said, I crashed into dialysis. You had my blood work. You had my urine analysis. There was protein in my urine. I mean, my blood work, my creatinine level was 13.5 when I went to the hospital. So I find that simply unacceptable that the system would not find that, because if we identify kidney disease, liver disease, if we identify it early enough, then we can look at slowing the progression. And there are many medications out here that can be used to stop the liver from losing its functionality, stop the kidneys from losing its functionality. You can continue on with a quality of life, and you can get educated to know what your options are.
Absolutely. Both the renal function tests and the liver function tests are part of a comprehensive metabolic panel that any primary care doctor, any endocrinologist, certainly any specialist, any doctor can order for a patient. And too often, as you just pointed out, those values, those lab values are not scrutinized, are not looked over, referred to, or patients are just told, don't worry about it. And that the lack of urgency around early diagnosis of liver disease and kidney disease, when there are opportunities to intervene and have preventive and protective measures, is a lost opportunity, and it really is unacceptable. And I'll tell a short story of my own. So as most people know, I am now 26 years post liver transplant, very blessed. But a large proportion of liver transplant recipients go on to need a kidney transplant. And I don't feel that is explored enough. And even though I am, have always been treated at very, top level academic medical centers, when my creatinine first started to be elevated, 15, 20 years after transplant, it was referred to kidney transplant, and the first words out of the doctor's mouth were, do you have someone who can donate? And I was like, hold up, let's just wait a minute. This is my first elevated creatinine. Well, I mean, clearly there was urgency in that state, but I think of the wrong type. And so, that was almost a decade ago. And my creatinine has maintained the same, but it's because I've asked gastroenterology and nephrology and push them to partner so closely to make sure that I stay hydrated, that I have protective antihypertensives. Even though my blood pressure isn't high by normal standards consistently, and that I now have diagnosed with anemia of chronic illness, and so I get EPO shots and iron. So the burden on my kidneys has been significantly lessened, and so we're able to preserve and maintain native kidney function. But it's always stuck with me that they were all too willing to accept that she's just going to need another transplant, and weren't willing to do any of those steps in between.
That's right.
To maintain my own kidneys, to maintain my own organs. And having gone through a transplant, I know that it is an arduous experience, physically, psychologically, to just sort of cavalierly assume that someone should go through that again, assuming I could even get an organ. Was really shocking and disturbing to me, and something that I want to make sure that doesn't happen to other patients.
And that's why jointly we have to educate. We have to educate them to ask questions. And I tell patients, listen, I respect that you have a relationship with your doctor, but say, for example, if you're headed towards dialysis, you might ask the doctor, well, can I get a preemptive transplant? No, I don't. Well, why not? Why do I have to go on dialysis if I have brothers or sisters who could provide me or give me a kidney and they're willing to do so?
Absolutely.
Well, that's not, and that's okay. Well, just go get another nephrologist, because that's your life. And the thought of having to go on dialysis, and there's no guarantee. But from a patient perspective, what we talk about is we at least want to explore and look at the choices. We want patients to have the choices in concert with our healthcare team. And I'll tell you, as livers go bad, generally it can have an impact on the kidney.
Absolutely. Another option I want to make sure that we talk about is home dialysis, peritoneal dialysis, because again, too few patients are given that as an option. And for those who want to stay, as productive as possible, to travel, the data on the effectiveness of peritoneal dialysis and the ability to integrate that into a person's life, it's often not shared with patients.
Absolutely, we need to rethink the whole concept of dialysis. As I tell people, we have to be aware of the false prophets of the status quo. Peritoneal dialysis is a great option for many people. And now, one of the things that happens when you do PD is that there's a possibility of the area getting infected and scarring up. But what they have now are some products that are coming onto the market that will let you know if there's any hint of infection long before it takes hold. And it's those type of innovative things that would allow you, for example, to stay on PD for a much longer period of time. And when you're on PD and you dialyze longer, it's better for your diet. You feel better. You have more energy. And the ultimate question is, if you ask most nephrologists if they had to go on dialysis, what would they do? A, they're going to tell you home dialysis, and B, they're going to tell you PD. So why are all your patients at the center?
Right. Exactly. So, this is why I all of this type of information and this knowledge, this sharing of hope is so important, and something that I know that will be featured even more highly and spotlighted on World Kidney Day on March 11th, and as part of your Living Well with Kidney Disease. So would you, I know we've talked about that a little bit more, but what are your hopes for that day and that initiative and that educational message?
Well, I'll tell you, we've been fortunate enough to be involved early on with the Joint Steering Committee and setting up World Kidney Day. I had the good pleasure of working with myself and several other authors and people from the Joint Steering Committee to do an article on living well with kidney disease, which is a very, very informative article, and I had a lot of input on it. But it was well done by some people that are really on top of it. And what we want to do is, again, we're going to take the day, we're going to educate people throughout the world. The good news is that the agenda that we have for World Kidney Day really aligns with our organization, AAKP, with the agenda that we have for our global summit, which is going to be May. I'll remember the date in a second, but the point is that we would have an opportunity to communicate with thousands of patients throughout the world. The sessions will be pre-recorded, and we will run them throughout the day. We're working on social media, and our staff does a great job of promoting information on social media. So we hope to get a lot of people to come out and to the 2-day, March 11th, March 12th.
Amplify that message as well.
I'm sorry to hear you.
We'll absolutely amplify that message as well.
We certainly appreciate that. And it's going to be exciting. I talk about living well with kidney disease, but it wasn't always easy. And we just have to be more educated, ask the questions. I'm fortunate. I had a nephrologist that's been with me since 2004, very progressive guy, and has educated me about how to look at my numbers, what not to be alarmed about. I have a relatively high creatinine level, but all my other numbers are great. Okay. So for you, this is where you are. Each individual and each patient is different. So I've been fortunate, haven't been sick in a while, and you can't talk about World Kidney Day and not talk about what's going on with COVID-19. Which is just like an additional challenge for us individuals who are immunosuppressed. And so as an organization, I know you mentioned you were going to be talking about that in one of your sessions. And as an organization, we've done 10 webinars that people can look at. We post everything. Just want people to know that it's true. They can go and look at it so that they can. I hate it when they politicize things. I just want people to be able to get the information and make decisions. Because when you have information, it takes away the fear. If you're 70 years old, you're immunocompromised, you're an African American living in Prince George's County, which has the highest rate of COVID-19 in the state by far, you're living in fear. And as I said to patients, I'm not going to live in fear. I'm careful. I wear my mask, wash my hands, and I'll go out to the stores. I'm not going to go to any public venues, but we do have to live our lives and do sessions like this.
One of the things that's been most important for me as we talk about COVID-19 vaccination and prioritization is that the different chronic disease communities are not pitted against each other. We all have, we are all at risk. And many of us don't just have one condition. We have, concurrent conditions and risk factors. I think the important steps to me have always been making sure that there is enough vaccine, having distribution methods that reach people where they are rather than expecting people to be, if you need, multiple 25-year-old grad students to get you on their computers and multiple devices to get you a slot, that is not a good system.
That's right.
That system does not work by definition. And so, not only the pharmacies, but the churches and federally qualified community health centers that already have relationships, with people and are, accessible, having people who are able to, walk up, because you can't assume they're going to be able to take off time from your job to,
that's right,
line or to do these things. It needs to, they need to be, it needs to be brought to people, and then the eligibility criteria needs to match the number of vaccines available, because the frustrations of people in the sense of being devalued for, by the time the people with chronic kidney disease, transplants, liver disease, who are supposedly prioritized, the reality is that, fifth, sixth, seventh in line. I think the assumption is that we're all frail and we never leave our homes, and that's not true. And so there's a very real sense, because of the decisions that were made, that we were not valuable, that we were not essential, that none of us were are essential. And that is not true at all. And so as we do get vaccines, it's so important that at this point it's a little bit on faith, because as you and I discussed, not many of us were included in the trials.
That's right.
The implications for those of us with complex diseases, getting sick, being hospitalized, having severe illness, the cost to ourselves, our families, everybody who depends on us, and to the system, are potentially immense. And so, if economics is what interests people, we also qualify for prioritization on that remark as well. And then there's the emerging evidence on how our immune systems incubate variants. So for so many reasons, kidney patients and liver transplant recipients and those who are immunosuppressed and immunocompromised need to be a higher priority and need to have, again, a sense of urgency in terms of reaching us and providing us with the highest quality vaccines available.
I always smile, because the people that are making a decision, that's not a value to them, or else it would have been done. And I said that's where patients have to align and get more engaged. And particularly, again, here in Prince George's County, we have such a high percentage of COVID in the state, and they were giving us grief because we had the lowest number of people that were vaccinated. And I said, we can do better than that. Mm-hmm. And I'm saying, where's the Black Caucus? Where's some of the other people? Right. Getting after the governor to give us more because we need it. No special treatment. And so I say, for us, we need to make certain, I would like to see patients get the vaccination at a dialysis facility. That would be nice. Exactly. Particularly for older patients, because most people go on dialysis when they're older, except unfortunately, we have more people who are younger and younger with diabetes, high blood pressure, other comorbidities that lead to loss of their kidneys. But again, we need to continue to work collaboratively to put that information out there and to let patients know that they do have a voice.
I also think that the scientific evidence around people who, what it means to reach the age of 50 for an African American, and should the age be, lowered? So, is your life expectancy and outcome for somebody with chronic diseases as an African American at 50 more similar to someone as a non-minority patient of 60. So when you look at the ages and things that on their face might seem to be generally applicable, if you look deeper at the science and the data, equal might not be equitable. I think that exploration of science and a fearlessness in terms of bringing it forward is very important. I see we have a question from the audience, and
okay.
I'm going to see, and it also is from I know someone who is waiting for a kidney transplant herself, who's asking a question about patients with HRS1, hepatorenal syndrome 1. One of the few areas where liver and kidney are explicably linked. And we've been advocating for new treatments for that patient group. Very sort of small, under recognized group of patients.
I was going to say, Julie, kidney and liver transplants are rare, but still. So what is the question? How can we? Well, let me say this: we spend a lot of time talking about rare diseases or rare conditions like that. Anyone who has a question of that nature, to feel free to reach out to our organization. I would like to talk about a colleague of mine who serves on our board of directors. He has a kidney transplant, but recently he had some issues: rapid heart beating, heart rate elevated, and as it turned out, he may need to have a liver transplant. He's had a history of cholangitis, and he may, depending upon how things turn out. As a matter of fact, I believe he will be getting checked today. So we're all praying for him and hoping that everything turns out okay. But we're just hoping that he can forestall that liver transplant. He already has a kidney transplant. So we're just hoping and praying that he will come out of this okay. It's a unique condition.
And thank you so much. Richard, it's one of the many conditions, unfortunately, I have had personal experience with.
Is it?
But yes, I try to check all the boxes, and but thankfully I was able to make it to transplant. But too many patients, unfortunately, do not have a bridge and do not survive. They progress too quickly, and they die before that option is available. And so, having treatments available for rare liver diseases, for acute liver injury, is as important as some of these long-term innovations and things that we normally discuss.
Oh, absolutely.
For helping to raise that issue. So I'm going to bring this fantastic conversation to a close. I keep you forever, but I'm so grateful for being here.
Up against the clock.
Being here today. So what can we do more of together in the future? I know we're working on living donor protection legislation. Can the liver health and kidney health communities work more closely together?
And what I would encourage is, and I would certainly do it from our side, for our folks to get more educated about liver, to visit your website and get engaged. And similarly, as your people have questions about kidneys, and I think many instances there are going to be some issues or some questions, feel free to visit our website. If I can just share with the people a couple of things.
Please.
We're having our global summit on May 13th and 14th. We do that in concert with George Washington University. Mm-hmm. Last year, we reached over 20,000 people in 70 countries. Then we do a policy summit, and that might be something that you can look to be involved in, where we talk about issues that are dealing with the kidney community, but certainly there's some crossover areas there, something like the Living Donor Protection Act and things of that nature. So we can look at that. And then we have all these are virtual. All of them are virtual and all of them are free. And then we have our annual patient meeting. That'll be on September 24th and 25th. So love to have people come out, join us, get some education. And, if you have something of that nature, please share it with us and we'll let our patients be aware of it. But I think that this was a great session. I learned a lot and we should do it more often.
Thank you. I look forward to that. And we will absolutely put links to all of that information in the show notes and that people can find it on globalliver.org and on Facebook, on Twitter, on Instagram and YouTube and wherever we can promote it.
Social media reigns.
Yes, that's mm-hmm. But thank you for everybody for watching. Thank you in advance to our digital editor who will fix whatever happened with my Wi-Fi today. Thank you, Richard. Thank you, AAKP, for being such a fabulous force for good in the world.
Thank you.
Until next episode of GLI Live. Be well, stay connected.